And good morning, everybody. Today I have the pleasure of introducing our grand round speaker, Dr. Julia Arnsten. She's a professor of medicine, epidemiology, and population health, as well as psychiatry and behavioral sciences at Albert Einstein College of Medicine and chief of the Unified Division of General Internal Medicine in the Department of Medicine at Einstein and Montefiore Medical Center. She's been continuously funded by the NIH since 1998. And has published over 200 scientific manuscripts. She was the founding chief of her institution's Division of General Internal Medicine in 2004, which today consists of 60 clinician educators and 15 clinician investigators who conduct research in a variety of fields, including substance use disorders, HIV and Hep C prevention and treatment, antiretroviral therapy, adherence, Hep C treatment, tobacco cessation, and most recently, medical cannabis. Since the division's founding 20 years ago, its faculty members have been the PIs on over 80 grants, representing over $200 million in extramural funds. In 2017, after medical cannabis dispensaries were fully functional in New York State, Dr. Arnsten launched a medical cannabis program at Montefiore Medical Center located in the Bronx. To date, the program has evaluated over 1,500 patients for medical cannabis. In addition, investigators in her group have received NIH and other funding to study the impact of medical cannabis on a range of medical conditions, including chronic pain, use of opioid medications, neurocognitive function, and inflammation. Please join me, everyone, in extending a warm welcome to today's grand round speaker, Dr. Julia Arnsten.
Thank you so much. I really appreciate the opportunity to be here. I'm going to start sharing my screen right now. Okay. Can you hear me?
Yes.
Yes.
Okay. Okay. Awesome. Okay. So this is a really hot topic.
Dr. Arnsten, could you give it a go full screen with your slides if you get it?
Oh, okay. So sorry. Yeah. Okay. There we go.
There we go. Perfect.
Okay.
Perfect.
Okay. So as Dr. Smith said, this is quite a hot topic, and I hope during my talk to, in addition to what I have written on this slide here and in my learning objectives, also give you a sense for how we as primarily primary care and addiction trained physicians at our institution have tried to draw a distinction between medical cannabis and adult use or recreational use cannabis, how we talk to our patients about it and how we talk to our colleagues about it. So I'm really going to tell you a couple of stories why and how we opened a medical cannabis practice in an academic medical center and also received funding to study the outcomes among chronic pain patients taking opioids, a particularly at-risk population for adverse events. And our question in pursuing this research has been, can medical cannabis reduce the risk of harms from opioid use among people taking chronic opioids who have chronic pain? So I have no conflicts of interest. These are the learning objectives that I sent ahead of time. I'll try to give you a good sense of the clinical trial data and the real world evidence regarding medical cannabis as distinct from adult use or recreational cannabis. I'll also tell you something about the strategies that we use for discussing cannabis with patients, which very importantly include identification and for cannabis-associated adverse outcomes. And so this is an outline of the talk. We'll go through why the topic is important, some laws in the United States, tiny bit of physiology, tiny bit of history, and because I'm a general internist, I know a little bit about a lot of different things. And so you'll see that in this talk. And then I'll go in some depth through the evidence for cannabis and chronic pain, and then our experience establishing a medical cannabis program in a safety net hospital. But why is this important? So this is a slide from the National Conference of State Legislatures, and it shows, it ends in 2020, but it shows the years on the x-axis and the number of states with cannabis legalization on the y-axis, and you can just see the, this is not a genie that's going back in the bottle. This is not going to be turned around anytime soon. So that's where we are with legalization of medical cannabis laws and adult use cannabis laws. About twice as many states have legal medical cannabis as have legal adult use cannabis. Kentucky is one of those states right now that has legalized medical cannabis, but not legalized adult use cannabis. New York had been a state like that, but just recently switched to a state that has both legal medical cannabis and legal adult use cannabis. And this is just a schema of the United States. The different colors represent different types of approaches to cannabis legalization. And so the light blue, what are these, hexagons, represent states with both medical and adult use cannabis. The dark green hexagons represent states with medical only. And with respect to medical only, there's another category, which is CBD only, which I'll talk about. And that is represented in the lighter green. And so you can see we're really a mosaic of different policies all over the country. And on the right is just a sample of a New York State medical cannabis card. In New York State, the medical cannabis program was rolled out in a highly regulated, highly medicalized way, which you'll see some examples of during my talk. And it's unlikely that a program will be rolled out that way again because of the way that this issue is going in this country. Now, why do people come to us seeking medical cannabis certification? The vast majority come for pain. So on the pie chart, the blue wedge that is the largest represents people seeking, the percentage of people seeking medical cannabis certification for chronic pain from a large electronic medical record database, and 61,000 patients. So the vast majority are coming for chronic pain. The next biggest slice is other, but after that, it's anxiety, and then post-traumatic stress disorder, depression, and insomnia. So we all know as internists that many of these conditions overlap with other medical conditions that people have. And so we need to be very thoughtful. We talk to patients about their cannabis use in the setting of other medical conditions and other medications they may be taking. Let's talk a little bit about the laws in the United States. This is just another schema showing in dark green again the states where medical cannabis, where cannabis is legal for adult use, non-medical. The lighter green is medical use, and the orange is no program. Now, on this map, Kentucky is in orange. What I learned about Kentucky is that Governor Beshear 2 years ago signed an executive order making a medical cannabis program possible, but it was by executive order only. But recently, the state legislature in Kentucky, or more recently, passed a medical cannabis law, which is going into effect for you in January 2025. So that's good. So why do we have all this variation across states? So cannabis is an illegal Schedule I drug under U.S. federal law, and that was that's under some discussion right now. It has been most recently reclassified as a Schedule I drug by the FDA. There's some talk about whether the Biden administration will try to reschedule it to a Schedule III before the end of the Biden administration, but it's not clear what will happen with that. So it is currently a Schedule I drug under US federal law, meaning there's no currently accepted medical use, high abuse potential, and lack of accepted safety. And yet we have all of these states and the District of Columbia that allow medical cannabis use. So why can we have that? We have that because over time, a series of United States justice officials Department of Justice officials have rewritten a memo which says that if the states have medical cannabis programs and now adult use cannabis programs, the federal Department of Justice will not interfere with those programs. So this entire system is built on this series of memos that allow states to choose to have medical and recreational cannabis programs. And so these become very complex issues which are worked out largely at the level of the state legislature. And what that has resulted in is a situation where the conditions, the qualifying conditions under which somebody can certify a patient for medical cannabis use are different from state to state and are generally decided upon by committees of non-physicians. But most of these conditions include these, some not very common and some very, very common. So ALS, cachexia and wasting syndromes, MS, cancer. When we started our medical cannabis program, we knew we would get referrals from the services who take care of those patients. But what we didn't anticipate that there would be really not very many compared to the number of patients with chronic pain. Just, you know, and I'll show you the data on this towards the end of the talk, but, you know, varieties of chronic pain for which they are either already using or want to use medical cannabis. But nonetheless, every state has a set of conditions. Most include these, and most have chronic pain as a condition without requiring it to be neuropathic or have any imaging related findings. And then most recently in New York State, and it seems that this will be true in Kentucky as well, this additional qualifying condition has been added, which is any condition deemed clinically appropriate by your healthcare provider. So this really leaves it up to us as physicians to be able to talk to patients about this because they may come to us and ask. So here's what I learned about Kentucky. In March of 23, Governor Beshear signed this bill, which had been passed by your Senate, legalizing medical cannabis for Kentuckians beginning January 1, 2025. And the Commonwealth will ensure that patients have access to medical providers and treatment for qualifying conditions. I don't know how the Commonwealth will do that. Medical products are contaminant-free, so the state has to put in place a system for testing products for contamination and labeled accurately to inform patients and caregivers. So the products have to be labeled in this volume or quantity. There is this much THC, there is this much CBD, there are this many other cannabinoids. And I'll tell you more about what those terms mean. And so the state has to do all these things and make sure that people are operating safely and responsibly in a variety of ways. This is just a little bit of coverage from when that bill was passed, the final day of the 2023 legislative session. And these are at the very bottom of this slide, what will be the medical conditions in Kentucky. Any type of cancer, regardless of stage, chronic or debilitating pain or seizure disorder, MS, spasms or spasticity, chronic nausea or cyclical vomiting syndrome that's proven resistant to either conventional medical treatments, PTSD, and any other medical condition or disease that the Kentucky Center for Cannabis determines. So this is also going to be a moving target for you all during the initial years of the rollout of the program. Apparently there's great interest, and this is the governor signing the legislation. So why does cannabis work? What does it do? Does it do anything? So let me talk, I'm going to talk for a few minutes about the botany and then the physiology, the botany of the cannabis plant, the physiology of the endocannabinoid system, and then the history of the use of cannabis really in the world. So we know that the plant has been cultivated by humans for almost 10,000 years. And this initially happened in Southern and Central Asia, and then moved around the world, essentially following the same routes as trade, including the slave trade. And there are known to be over 700 plants in the cannabis family. The one with which we're most familiar from biochemistry studies is the cannabis genus species sativa. And within this sativa species, there are actually two different subspecies, which are called sativa and indica. And the sort of conventional wisdom about this over these thousands of years, but not so borne out by the chemical analyses that have been done in the last 40 years, but still generally have some truth, is that the species that is the sativa species is higher in the cannabinoid THC. And that's important because the THC operates differently in the body than the CBD. And the species that is called indica, cannabis indica, is generally higher in CBD. So the indica species still has THC and can be bred to have high THC. The sativa species still has CBD. There are also many other cannabinoids and another class of molecules called terpenes in these plants. And then there's hemp and hybrids, which are really essentially just different combinations of the cannabinoids in the plant. So hemp is a cannabis plant that has less than 1/3 of 1% THC, and hybrids are anything between the sativa and the indica extremes of the range. The pure sativa and pure indica look a little bit different, and I've put some cartoons here and some pictures. So a couple more words about THC and CBD. I put the chemical formulas here so that you can see that they're very, quite similar molecules with a few differences. The THC, the delta-9 tetrahydrocannabinol, is the most well-known and best studied cannabinoid. It was first identified in the 1960s by an Israeli biochemist. It's psychoactive and intoxicating. Plants are often bred for high THC content. It affects pain, muscle spasm, appetite, nausea in many, many, many different kinds of animal models and in humans. But the dose is limited by adverse effects, which include cognitive dysfunction, slow reaction time, short and long-term memory loss, dry mouth, red eyes, other side effects that may be less common but more bothersome for some or more dangerous. Now, CBD, cannabidiol, was identified around the same time in the same lab. It's an interesting story. The lab was, as I said, a lab in Israel. The biochemist Raphael Meshulam, he just passed away a few months ago in his 90s. And he was very interested in the endocannabinoid system and in cannabis because he observed that people really like to use it. And so he would get his supply of cannabis from the police in Tel Aviv, and they would just give him the hashish that they confiscated, and then he studied it in the lab. And he was able to identify, to isolate and identify these two molecules. So the CBD is, some people say it's not psychoactive. I prefer to say that it's psychoactive but not intoxicating. And the reason that I prefer that is that it seems to pretty clearly have anti-anxiety properties in humans, but we don't quite know the dose yet. And so to me, that's a form of psychoactivity, but it is not intoxicating in the way that THC is. And it doesn't have the same negative adverse effects neurologically. It doesn't produce cognitive dysfunction or slow reaction time and memory loss. And at the same time, combining both THC and CBD seems to allow the THC to work more effectively on some of the symptoms that we would like it to work on, like pain or muscle spasm or anxiety, allowing a lower dose of THC with fewer THC-associated adverse effects. It just is just a summary of the THC versus CBD. It really talks about some of the same things that I said in terms of the CNS effects. The THC is more intoxicating, more sedating, and has some other properties that originate from the receptors in the brain that CBD does not have, which are anti-nausea and appetite stimulation. CBD we have observed in cell culture to be anti-inflammatory. THC is more analgesic, but the impact of this is likely potentiated by CBD. And the other things that I said about the sativa being predominantly THC, indica predominantly CBD. Plants bred for high THC use are very popular for recreation because the intoxication can be quite intense and even hallucinogenic. We're trying, the National Institute of Drug Abuse has suggested that we could work with a standardized dose of THC of 5 milligrams, but I'd say this is still pretty much up for grabs. There are 2 FDA-approved cannabinoids, both available as pills. One of them is dronabinol. This is a synthetic form of THC, trade name Marinol. This was, I think, early 1990s, that era for appetite stimulation in people with advanced HIV. And the effectiveness of dronabinol was one of the things that really stimulated the movement for legalization of medical cannabis because of people who were politically active that had come out of the HIV community. Nabilone is another synthetic cannabinoid agonist, very rarely used in this country. And then there's another drug, which is called nabiximols, which is available in many other countries, but not ours. It's an oral mucosal spray of 1-to-1 THC and CBD. And many of the studies that we have, which tell us the impact of cannabis on pain, were done with this drug, which is complicated because we don't have this drug in this country. And so we're trying to extrapolate the data from what we do have in this country. And then the FDA approved Epidiolex, which is CBD derived from the cannabis plant for severe childhood epilepsy about 4 years ago. And this is being used for kids who have severe epilepsy. So just very briefly about the endocannabinoid system. The cannabinoid receptors, the CB1 and CB2 receptors, were also identified by that same Israeli biochemist lab about 20 years later in the 1990s. So, why does the body react to the cannabinoids to which it's exposed? It reacts because it has these receptors. It has the CB1 receptors, which are depicted in this photo in green, and the CB2 receptors, which are depicted in blue. And the THC binds mainly to CB1 receptors. CBD seems to bind to both receptors. So these are located all over the body. And what do they regulate? Well, they seem to regulate THC and other cannabinoids. So the CB1 in the brain regions that are active in the pain path, but are also present in many other organs and tissues. And the CB2 receptors are very highly represented in the immune system. So the next question that this lab, Dr. Meshulam's lab, asked was, do we have endogenous ligands for these receptors? Because why does our body have these receptors? And it turns out that we do have endogenous ligands for these receptors. They're retrograde neurotransmitters, anandamide and 2-AG. And through a series of experiments, it's been demonstrated that both of these endogenous ligands are important in the pain response and also in how the body regulates a wide array of other processes like appetite and mood and stress. All right, now we're going to move on to a little bit of history. Just a little bit of history going back to 2700 BC. And so this really around for all of these years. We've known about it. It's been, and I'll show you some of the early references to it. And then you can see on the top in green, Dr. Meshulam, who I was talking about, identifying the cannabinoid molecule. So the cannabis spread around the world over about 5,000 years, 2,000 years BC or before the Common Era to roughly 2,000 years after that, which is where we are now. And the initial spread was from Central Asia to India, Egypt, Greece, the Roman Empire, the Arab world, and later on from Asia and India to Africa, South America, and ultimately Europe and the United States. We began to have widespread cannabis use in Europe and the United States in the 19th century. So during the 1800s, in cannabis extract of hemp was in the United States pharmacopoeia, and it was thought to act in all of these ways: appetite, inducing catalepsy, producing sleep, pain. And then in the early part of the 20th century, there was a major shift in US policy with prohibition. And with alcohol prohibition, many states also banned cannabis, but some doctors still prescribed it. At the same time, vaccines and other new drugs like aspirin and analgesics were being discovered, and that made it less necessary to use this tincture of cannabis. By the 1930s, cannabis had become very unpopular by the government. And there was a large campaign to rebrand cannabis as dangerous and associated with illegal immigrants. Particularly, there had been a spate of Mexican immigration at that time, and the United States government renamed cannabis marijuana, some people believe, to associate it with Mexican immigration. There were a variety of propaganda films, A Good Girl Until She Lights a Reefer. And then in 1937, there was the Marijuana Tax Act, imposed taxes on manufacturing or selling cannabis, and also administrative burdens for doctors. So after that, cannabis prescriptions declined rapidly, even though the AMA was opposed to that. And by 1942, so really, not just 60 years ago, that cannabis was removed from or 80 years ago, cannabis was removed from the US pharmacopoeia. And then the next 20 years, as we all know, saw the birth of the war on drugs, the creation of the DEA scheduling system by Nixon, marijuana being categorized as Schedule I. As I said before, no currently accepted medical use, high abuse potential, lack of accepted safety. And there were harsh marijuana laws used to crack down on the counterculture. By 2010, one in this country every 37 seconds. The arrest rate for whites, despite use, documented at nearly equal rates. And at the same time, we began to see really intense demand for legal medical cannabis. And so in the 1990s, the first state, California, to legalize medical cannabis did so in 1996. And that, as I said earlier, was really spearheaded by political activists who had come out of the HIV/AIDS era and had seen benefits from using cannabis on weight and appetite stimulation. And then from 1996 till about 2010, you saw a lot of states legalizing medical cannabis. That's the red dots. And then in the blue dots, some states beginning to legalize adult use cannabis. And this ends in 2006. But as I showed you earlier, we're up to 39 states with medical cannabis and about 20 with legal adult use cannabis. So why? Why do we want there to be all this medical cannabis? Does it work for chronic pain? Does it affect opioid use? And does it help with reducing the adverse effects of chronic opioid use? And in other words, help keep people alive. So this is really the million-dollar question. Is medical cannabis an alternative to opioid medications for chronic pain? And the National Academies of Sciences, Engineering, and Medicine looked at this question, and they issued a report. They're redoing it because it was in 2017, so it was 9 years ago, no, 7 years ago. And at that time, there were about 25,000 articles looking at the health impacts of cannabis and cannabis-derived products. Now there's probably twice that. And this is what they found. So they did this extensive look, all this literature at that time, very distinguished panel, and they concluded that cannabis or cannabinoid-treated patients are more likely to have a significant reduction in pain syndromes. So they said there is conclusive or substantial evidence that cannabis is effective for treating chronic pain. Now, I just want to give people in the audience who are internists a sense of what that meant. So the conclusive or substantial evidence that cannabis is effective for treating chronic pain, if you want to think about it in terms of what's the clinical impact, how effective for who. About half of patients get a significant reduction in their pain. The pain doesn't go away. So what is a significant reduction? Significant reduction is on a scale of 1 to 10, how bad is your pain today? The answer to that question goes down by about 3 units. So that's what we're talking about. So we really need to manage expectations when we're talking to patients about cannabis for chronic pain. And what I say to people when they're sitting in front of me is, if I had 2 people exactly like you sitting in front of me, the cannabis might give one of you relief and one of you not. And we won't know until we try. We have to do a careful trial, write down what happens, and then we'll make a decision about whether to continue it. This is another thing that they said. While the use of cannabis for the treatment of pain is supported by well-controlled clinical trials, very little is known about the efficacy, dose, routes of administration, or side effects of commonly used and commercially available cannabis products in the United States. And this is because most of the well-controlled trials have been done with products that we don't have in the United States. There's 2 other conditions for which this panel also noted substantial evidence of effect. So that's going to be 3 conditions: chronic pain, and the other 2 are chemotherapy-induced nausea or vomiting, and spasticity associated with multiple sclerosis. So in 2017, which was the last time we had this kind of work done, it's being redone right now, there were 3 conditions for which this body felt that there were substantial data supporting the use of medical cannabis, and there are chronic pain, chemotherapy-induced nausea and vomiting, and spasticity associated with multiple sclerosis. So let's talk about chronic pain. Chronic pain is pain lasting 3 or more months or past the time for normal time for tissue healing. We all know it's common and is a major cause of decreased quality of life and increased disability. Existing medication options that we have provide modest relief with many side effects. Opioids in particular cause constipation, impaired sleep, respiratory depression, and most importantly, we have no good quality clinical randomized trials supporting efficacy of opioid medications for pain lasting more than 90 days. And yet, I'm sure that we all have seen in our practices patients who've been on chronic opioid therapy for years. So despite this, we've seen opioid prescriptions for chronic pain increasing dramatically. And this trend has been accompanied by greatly increased levels of prescription opioid overdoses, by opioid use disorder, the rise of fentanyl, many other catastrophic sequelae. Pain relief is the most frequent condition reported by medical cannabis patients. I started the talk with that statistic, and in New York State, it's nearly 75% of medical cannabis patients. So I just want to show you a little bit of the data that the panel used when they came up with the recommendations that I spent some time telling you about. So these are 7 meta-analyses of randomized controlled trials of cannabis and cannabinoids for pain. So each row represents one meta-analysis. So the top row meta-analysis was published in 2007. They looked at 7 studies. The bottom one was published in 2017. They looked at 27 studies. So that's how this table is organized. Then the type of pain is in the middle column. And you can see that most of them are multiple pain etiologies. So what that means is that you have a whole lot of different pain diagnoses, and it's very hard to identify a mechanism. What kind of medications were used? So now I've told you about these things: dronabinol, CBD, cannabinoid and plant-based medications. This was not in this country. Cannabinoid and plant-based medications, inhaled cannabis. So you can do studies with plant-based cannabis in this country. You have to buy actually you don't buy it. You have to apply for the cannabis to the National Institutes of Health. National Institutes of Health has a farm where they grow cannabis, and they would give investigators cannabis in inhaled form, cannabis cigarettes, to use in trials. And that is, so when I said many trials are done with the oral tincture that is available in Europe, and then in this country, people are buying cannabis, that they're rolling into cigarettes on the street. How do we look at those two things together? So some of these studies included inhaled cannabis, but some of them did not. So these cannabinoid and plant-based medications are generally not available in the United States. Inhaled cannabis would be. But I want you to focus on the last column all the way on the right. For every one of these meta-analyses, and this is now getting into hundreds of trials, they showed significant decreases in pain outcomes, whether the pain outcome was pain intensity, pain reduction, or some other way of measuring pain. They all showed a significant decrease. How important clinically was that decrease? On average, people went down about 3 points on a scale of 1 to 10. Now, this slide is here to show you the difference between animal data and human data. So on the right, I have this one, the Whiting meta-analysis that was published in 2015 in JAMA. And on the right, you can see that several of the studies, the confidence interval, crosses 1. So they were inconclusive. Nonetheless, the summary statistic from the meta-analysis showed that cannabis improves pain in humans. But we have all this messiness about the data. Now, contrast that with the animal models. These are all animal models of pain. They do different things to the animals, and they measure how much pain they have. So I'm not an animal researcher, but from what I understand, the animal might be subject to a nerve injury, and then they do other biochemical censoring techniques to determine the level of pain that they're experiencing. And so in all of these papers looking at animal models, the cannabis improved the measure of pain. But we have a lot of trouble reproducing that in humans. This is kind of, the state of the science right now. There is a living review, effectivehealthcare.ahrq.gov. This is maintained by colleagues at Oregon Health Sciences University, and they're basically, as new data come in, putting in, reevaluating the strength of the evidence for each of these interventions. So this is the oral mucosal spray, 1-to-1, THC, CBD, oral high THC, this is dronabinol, THC extracted from whole plants, oral, that's a tincture, topical, oral, and just so you can see that the pain response is significant, but the strength of the evidence ranges from low to moderate, where we are right now. Now, what do people actually experience? So this is a longitudinal study from Israel of almost 3,000 cancer patients treated with medical cannabis. And what I want you to notice is that pain intensity is on the x-axis, and the blue bars represent before treatment with medical cannabis, and the orange ones represent after treatment with medical cannabis. And what you can see very quickly is that pain intensity in blue is concentrated on the right, and pain intensity in orange is concentrated on the left. Again, the blue is before cannabis treatment, the orange is after cannabis treatment. So these are data, this is evidence, but this is a cohort. These are people who remained on medical cannabis. But what it's basically telling us is that the people who stayed on medical cannabis thought medical cannabis was helpful. And so there's a selection bias in that kind of study. Some other data that we have supporting the idea that medical cannabis states have fewer opioid adverse events, so states with medical cannabis have fewer opioid-related adverse events, comes from these 4 trials. These 4 trials are all very similar. They were all done around the same period of time. And they're all trials comparing large cohorts of people. So Medicare prescription drug plan enrollees, Medicaid enrollees, hospital inpatients, and they're comparing states. So among all Medicare prescription drug plan enrollees in states with medical cannabis compared to states without medical cannabis, was there a difference in opioid prescriptions? And all 4 of these studies found in these different populations that in states with medical cannabis laws, there were fewer opioid prescriptions than in states without medical cannabis laws. So those are some data. The data have various challenges to them. But with respect to our evidence for the impact of medical cannabis on chronic pain, that's what we have. Now I'm going to tell you a little bit about our experience establishing a medical program in a safety net hospital. So why did we begin this? We wanted to protect our patients from arrest or parole violation because jail and prison are very negatively impactful on health. We want to prevent accidental ingestion of contaminants such as fentanyl, cocaine, xylazine, synthetic cannabinoids. We want to contribute to the data that tells us about specific ratios of THC and CBD. We want to promote safer delivery methods than smoking. We're doctors. We tell everybody, don't smoke. Smoking is the worst thing you can do for your health. We're not here to tell you go down to the dispensary and buy a marijuana cigarette and smoke it. We're here to talk about CBD specific doses, protect from other consequences that they could experience. Here we are in New York State, just showing you our little island of Manhattan, and then just above that is the Bronx. This is what the Bronx looks like. Population is almost 1.5 million. It is a majority minority, so 28% Black or African American, 56% Hispanic. People live at a median household income of 43,000. Over a quarter live in poverty, very heavily populated in terms of density, more than 1/3 foreign born, over a half speak a language other than English at home. So this is our population. So how did we establish the program? Well, first of all, we decided it was important. And then, we met with our key institutional stakeholders to see if they thought it was important too, and some of them did. And that was one of the first things that was really consequential, was finding our partner. Then we read very carefully through the literature to develop best practices for rigorous, safe evaluation of patients seeking medical cannabis. I'm going to talk a little bit more about this when I get to it, the harm reduction principles. Okay, so key institutional stakeholders, this is EPIC. You may recognize it. We met with our EPIC IT team, and we request an inpatient medical cannabis consultation. So we thought, we've learned all this. We're gonna educate everyone else about it. We're gonna make ourselves available through various consultation means. So if somebody has a question, I have a patient, might they be good for inpatient for medical cannabis? We'll come see them in the hospital and talk to them and talk to their doctor about it. And we work with IT to make that happen. Then we started to have this is me several years ago, a variety of case conferences, discussing what we learned. We published our initial experiences in the New England Journal. 6-step process to determine the risks and benefit. So we go through these 6 steps, which I'm going to tell you about. We take a thorough cannabis history. If they're already a cannabis user, when did they start? How often do they use? Why? Where do they get it? How do they use it? Do they add anything to it? And then to try to evaluate their exposure, we talk to them about how much they may spend in a week or a month, and then we go through this arithmetic on this in this yellow square, which basically is assumes that most unregulated cannabis is 20% THC, and then if people are buying cannabis plant material, we try to calculate how much THC they're using in a day based on how much plant material they're buying in a given time period. Now, with respect to harm reduction principles, we try to talk to patients about motivation. So, we would like people, even those who are already using cannabis, to use cannabis for relief of specific symptoms like pain or nausea, not because they're bored or because it, makes it easier to deal with someone in their life. So we do a lot of counseling about that. And we do a lot of counseling about delivery. I'm going to take you a little bit through this. I have a couple of minutes left. So I think this is important. So these are the modes of delivery. I will say that we strongly urge against the top 2 rows: dabs, waxes, and combusted flower. So what are these things? So dabs and waxes are highly concentrated cannabis resin that you have to light up with an intense flame and then inhale the vapor. We don't recommend this. We can talk to people about their cannabis use, and they tell us they're we try to, really encourage them not to do this. So it's just not safe. Combusted flower. This is the most commonly known form of cannabis. It's the little bud like this. People like to roll it into cigarettes or put it in a pipe and smoke it. It comes on, the onset is very, very quick, minutes, very easy to titrate. and we have a lot of experience with it. It does have a clear risk of chronic bronchitis. We don't see a cancer risk with smoking cannabis unless it's smoked with tobacco. Vaporized flowers or oils were at some point considered a safer alternative to combustion. The material is heated at a lower temperature and the vapor is inhaled. The vapor might come from an oil or it might come from the flower itself. When we first started the medical cannabis program, that was the year of electronic vaping associated lung injury, EVALI. And so we were really steering people away from vaping. My personal view on this is that if someone's not already vaping, don't start them. We just don't know enough about the long-term effects. If somebody's already vaping, try to move them to another delivery system. So what delivery systems do we like? We like sublingual tinctures because you can titrate. You know exactly how much you're going to get. You put it under your tongue. It doesn't have any of these other associated problems. For the first couple of years of the medical cannabis program, we started everybody with sublingual tinctures. We would start them with a drop. Naive patients, we would start them very, very slowly. And so that's what we recommend. Problems with it, doesn't taste good, and it's messy. And this is finally the ingested form. So this is, taking a pill or taking a gummy and putting it through your digestive system. Long duration of action, no pulmonary side effects. These are some tables that are lifted directly from New England Journal piece. So I think I'm not going to go through them, but a recipe for how to start medical cannabis with whether the patient is already using near daily or whether they're using not at all or infrequently. And so these are the steps that we go through. This is kind of a summary of that. Start low, go slow. People who are naive, cannabis naive patients, we start with sublingual tinctures, 1-to-1 before bed. Don't take any other sedatives with it. Keep it in a safe place. Don't go out. Titrate up over weeks. In experienced patients, it's a lot more complicated. We estimate the current THC consumption per day. We counsel them to stop using whatever they're using for 24 hours before transitioning to medical cannabis. Start at half the usual dose and titrate to the effective dose slowly. Use the safest route of administration, avoid driving or operating heavy machinery. And that's the same table. I want to make sure that I leave time for questions. And so I do want to just say a few things about unregulated cannabis. So all of the products I've been talking to you about are in the regulated market. That means that the exact cannabinoid dosing is confirmed by the state, tested for pesticides and other contaminants. And that's what your Kentucky program is going to be rolling out in January. At the same time, you will see all kinds of unregulated dispensaries and sellers, and patients get very confused, very confused. So we try to help them to understand the difference between We try to help them to understand the difference between the regulated market on the right generally and the unregulated market. So in New York State, the regulated market, they all have a New York State medical cannabis board label on the front. They have a QR code. The unregulated market tends to look like this. I don't know how it'll be in Kentucky. So with respect to what else we do, we published this article, as I said, in the New England Journal. These are some data from our article. The red here indicates how many patients we saw who had chronic pain. This is on the left is the number of patients that we're seeing over time. And this is just a little bit about who those patients are. So who are we seeing? So this is the Bronx population in the middle that I showed you before. And then this is who we're seeing. So we're seeing largely people of color. They're 57 years old on average. A not insignificant minority has an opioid use disorder diagnosis. And we see a lot of people with HIV and sickle cell disease. I'm going to skip over this for now. Okay, so what have we learned so far? That as I showed you, the program has scaled up quite a bit. We've seen a lot of patients. We have very long wait times for certification appointments. There's a complex online patient self-registration process that has actually been simplified a lot in the last 6 months, but for a long time was very hard to help patients navigate. And although we see the patients right in our primary care safety net clinic, our FQHC setting, doesn't cost them anything for the evaluation, they have high out-of-pocket unreimbursed cost to purchase medical cannabis. So I tell them, you're going to go there, you're going to buy a bottle of 30 milliliters of this tincture, and it's going to cost you $75. And people basically, burst into tears. So while we're waiting for the system and doing our best to help the system to become smart and rational, we can recognize that many patients are using cannabis, want to do so safely. We can communicate reliable evidence-based information, especially regarding consumption methods, and promote harm reduction and use our platform to educate other physicians. So we've written a few other guidelines, one for New York State, which is there. This is an up-to-date medical use of cannabis and cannabinoids in adults. This is by my colleague Deepika Slawick and myself. And I don't think I'm going to have time. I wanted to go through the results from some of our studies, but I don't think I'm going to have time. We've enrolled about 200 people in a large cohort analysis of the impact of medical cannabis on chronic pain and opioid use among patients with both. And I'll just tell you that of that sample, their baseline mean morphine milliequivalents were 65 per day, lots of pain interference, lots of pain severity, and lots of psychiatric comorbidity. The green bars are patients in our cohort compared to the light green bars, which are the general population. And we've seen over time, among over 18 months of people enrolled in our studies, change in pain score and participants with active opioid prescriptions over time, both decreasing substantially. So I just told you that. So with this study, we're looking at all kinds of things, and we have some other studies going on, and a lot of people helped. And that's it.
So thank you, Dr. Arnsten. I'll turn it over to Dr. Smith in a moment, but as the recovering cardiologist, I have to ask, the American Heart Association came out in February with an advisory saying that cannabis use was associated with an increased risk of both heart attack and stroke. And if I knew about it because I just Googled the words after seeing a case or two, and it turns out that they're claiming that marijuana daily has a 25% higher risk of having heart attack and 42% higher odds of stroke. Do you have any, first of all, mechanisms, but more importantly, ways of mitigation of this issue?
Yeah. No, I think I talked about so many things that I realized that I left out the slide with the serious adverse, like the contraindications. So I do want to say that. So if we have people with unstable coronary disease or active psychosis or pregnancy, we don't start them on cannabis. I know that's not your question. So we do know from a lot of models that the THC can cause tachycardia and like increased, work of the heart. I don't know the mechanism for that. And so like I've seen a few people that have not unstable heart disease, but have had significant coronary disease. And if they weren't already using THC, I said, don't use it. Now, if they're already using it, you still want to say don't use it, but you may need to, work with them over time to get them to slow down and, really go over the risks and benefits. Many of these studies, like the studies that I showed you, are done with mixing medical cannabis with recreational cannabis. You know, the amounts that people are taking are not really are very hard to measure. So so I think that we have to look at those data carefully and really try to understand what population they're in. But like with any patient, right, you have this conversation all the time, you know, like raise the diuretic, or, you know, like, so if the patient is in, you know, if the patient is in terrible pain and they have cancer and they're saying, this is what helps me, and they also have heart disease, you know, then that's the individual doctor's decision, right, to say, okay, if this is all that helps you, you know, let's try a very low dose or not, right? We each have our comfort level with that.
Thank you. Dr. Smith?
So, Dr. Arnsten, thank you for the talk. I think you started to touch on this just at the very end, but I wanted to follow up about the reduction of opioid use for patients who were using medical cannabis. Is it a goal to get people off of opioids? Is it a goal to reduce opioid use? And what do we know about using opioids and cannabis together?
Yeah, great questions. Great questions. So we are trying to use cannabis to help people to reduce their opioid use. You know, we all have in primary care and many other fields, lots of patients with chronic pain who have stopped taking opioids, and then others for whom it's been very hard to taper their opioids. And, you know, we were just asked this week, there's a rheumatologist in our group, in our department, who's retiring, who has been taking care of many patients for many decades. And some of them are on long-term chronic opioids. And no one, you know, none of the newer rheumatologists want to continue that. And so, you know, we see this as our role, is to help those patients to taper if they can, but also to recognize that, and this is a whole other conversation, but tapering can take years. There are some patients that can't be tapered. And, you know, so we have to recognize the risks of opioid tapering, you know, the risks of suicide and despair, and, you know, be very, you know, really develop communication styles to help patients to understand the importance of tapering and to help them feel like they're in control of the taper. So that is always our goal. It may be a very long-term goal.
All right, Dr. Arnsten, real quick, we do have a couple of questions in our chat area. The first is from Dr. Laura Bishop. She's one of our internal medicine folks, and she also helps coordinate our combined med peds residency program. And she wants to know, says, thank you so much for this. In the pediatric hospital, we see many admissions per week wherein children are ingesting the gummy formulations. I'm curious if there are any discussions when prescribing about safe use or storage to prevent these ingestions among children who may be in the household. Maybe it's, in parentheses, maybe it's less of an issue with other formulations.
Yeah, no, we actually do a treatment agreement for our medical cannabis patients. So as part of the treatment agreement, we go through safe storage. We encourage them to get a safe that locks. We talk about keeping the products away from children and pets. We talk about not operating heavy machinery. We talk about risk of psychosis. We talk about, you know, the need to let us know if there's any changes in their medical history, or, you know, anything acute happens. So we go through a whole treatment agreement when we initiate the medical cannabis. And you know, we really don't like to recommend medical cannabis to anybody who's younger than 25. And I wouldn't start anybody younger than 25, just like I wouldn't start anybody with heart disease. But if they come to me and they say, I have migraine, and this is the only healthy, or something like that, you know, I would conversation. Well, what form are you using? How are you using it? There's much safer ways to do that. Let's talk about those. Let's talk about getting a safer product and using it in a safer way. So that's how we handle youth.
Yeah, and she had a real quick follow-up just saying, so that's very helpful, and we are working on a QI project discharging families with medication safes after such a stay. It's often grandparents / parents who are using this, and kids tend to pick them up on the floor of the table. And one more question in the chat, and this is from Dr. Dawn Castor. She's in our nephrology and hypertension group. She says, do you have any data specific to patients with CKD with NSAIDs contraindicated? There are limited options for these patients. Also, NSAIDs increase CV events as well. Any comparison with cannabis versus NSAIDs on CV risk?
These are great questions. And, because we don't have standard formulations, that have been, like the only standard formulation that people can use for testing is what comes from the National Institute of Drug Abuse. That's really designed for studying adverse effects. So those marijuana cigarettes that NIDA gives to researchers are for people to do like a study in the hospital where somebody comes in, they smoke the cigarette, they get into a driving simulator, and we see how impaired they are. If we want to understand how taking a 5 milligram tablet of THC with no other cannabinoids or with very minor other cannabinoids and minor terpenes affects somebody's pain, we haven't had the capacity to do that because we don't have a supply or even a research infrastructure for doing that kind of research. So all of these questions like CKD patients, comparison of NSAIDs to cannabinoids for cardiovascular events, I hope that those have been a way to do them yet.
I'm muted. That doesn't help. If you have any more questions, you could post it in the chat or unmute. I know we're kind of running a little over today, but one thing, Dr. Arnsten, we have a tradition here at the University of Louisville, especially for our guest presenters, that we have a little gift for you. We're going to send you a little gift, and it's something that is very synonymous with the city of Louisville. So you will be receiving your very own
bat. Is it a bat? All
Louisville
right.
Slugger bat.
Yeah, great.
Yeah.
Great.
So,
one of my kids is a softball player. So
cool. Yeah. So we will we'll get that to you here in a few days or first part of next week, and we really appreciate everything. And Dr. Williams, do you have anything you'd want to close with before we head over to do the Cardinal Minute?
It's fantastic. Really appreciate all of your insights. It's an issue that's going to be so important for us in Kentucky, as you point out. And so thank you so much for all your time and your knowledge.
it's been my pleasure.
All right, everyone. We'll see you next week. And Dr. Let me stop.